Question from the audience. Another myeloma one. I was diagnosed with multiple myeloma in 2021. I'm age 66. I have never gone into remission. However, I feel good, my blood work is good, and I have a pretty good quality of life. I'm fearful that I cannot survive a stem cell transplant, so I've decided not to undergo a stem cell transplant for now. I'm currently on treatment plan with daratumumab shots once a month and oral Pomalyst. Is there something better? How safe is CAR T option? What are the downsides of CAR T cell treatment? A lot of good questions in there from one of our myeloma physicians, if they would like to answer.
Sure. Dr. Goodman, do you want to tag team this question because there are multiple components to it?
Yeah, I can do. So I can do the first one. I'm fearful that I cannot. So as a physician, I completely take into account your fears regarding transplant, and those are very reasonable fears. And as I spoke about earlier, unlike before where we had 10, 15 years ago, we didn't have all these great therapies for myeloma. I really tried to push my patients towards transplant. But in the current era, especially in a 66-year-old, I don't think transplant, I don't tell my patients, don't feel bad that like you're wasting a great therapy. There are many successful ways that your disease can still be treated without a transplant. It is by no means an absolute in today's era. And I know remission status in myeloma is a little confusing. In many patients, if you, as she was explaining earlier, there's partial response, very good partial response, and there's all these crazy response criteria. But don't get hung up, in general, less cancer is better. But there definitely are patients that can have partial remissions, very good partial remissions, where their M protein's hanging around, and they can have years and years of remission. As a physician taking care of someone with myeloma, what I'm looking for and concerned about is not the absolute level of the protein in your blood, okay? I'm looking for it going up, and more importantly, are you experiencing sequelae or problems related from your myeloma? Are you becoming anemic? Are you getting new bone lesions? Those are things that I follow. So if your M protein stays elevated but doesn't move and you feel great, that's a win. Keep doing what you're doing. There's no need to change. There's no need to become more aggressive. There's no data that would suggest increasing your therapy will make you better. It might lower your protein more. So that answers the first questions. How about you answer the second set of questions? And feel free to chime in if you disagree.
No, I don't. I actually do agree. And I'm pretty sure in our patient panel, there are very few patients for whom we have that beautiful M spike of 0. I want patients to know that, for most of our patients, when they come in with an M spike of, let's say, 3 or 4 or whatever number, what we are looking for is a reduction and the percentage of reduction from that initial number. So as long as it's going down, it's in the right direction and staying there with your current daratumumab Pomalyst regimen, which, by the way, is actually a really good regimen. If you're able to tolerate it. Pomalyst is a very good immunomodulatory drug, which is very good at keeping myeloma away for a long time. I think that is good. What we look for is often being in that plateau stage with the M spike or the amount of cancer in your body. And we all very often look for any change or increase in those M spike numbers. So completely agree on that. Now, I think you were asking about CAR T as an option. Again, CAR T as an option will be open to you once you have, and hopefully not anytime in the near future, progressed beyond your second line and third line and fourth line of therapy. And then CAR T becomes an option based on the current FDA label. Now, CAR T is something that we do consider in patients who are somewhat having a good performance status, meaning, there are patients who are transplant eligible or people who we typically consider transplant ineligible for some reason, but we can have some other criteria for CAR T. Essentially, we look at if you're able to, do a lot of the home chores of your own. Take a shower, dress yourself, do a lot of your groceries and other stuff on your own. And you're essentially able to take care of yourself, and you have an exercise tolerance of being able to walk 5 blocks, 10 blocks, etc. That would make us consider that you could be a good candidate for CAR T. We do have to give some chemo to condition your body before we give CAR T cells to you. That's not usually considered like high dose chemotherapy, typically the way we think of stem cell transplant. So yes, you will be getting a dose of chemo, and that is going to be intensive. But then, after your CAR T infusion, I think between Dr. Phillips and me and Dr. Ruiz, we all talked about all the side effects that you can have following CAR T. Mainly, we watch you in the hospital for 14 days very closely for cytokine release syndrome, which is this massive inflammatory reaction when the CAR T cells expand in your body and attack your cancer. We also closely watch for neurotoxicity. And at the end of 14 days, you go home and then we continue monitoring. For downsides of CAR T, I can't really think of any. It's proven itself to be having a very good efficacy in very heavily pretreated patients. And yes, you do have to have somewhat of that robustness in performance status to be eligible. For alternatives, apart from CAR T, for patients who are not quite there with their performance status, that's when bispecifics come into the picture, right? Again, you needed to have progress beyond a few lines of treatments, but bispecifics have really opened the door for more options for you. And I think bispecifics would be a consideration for the next line of treatment should you get there.